TMJ disorders. We'll be talking only about the key points. Now, one of the TMJ disorders is trismus. Now, trismus can be caused due to a lot of factors. Trismus may occur due to an inferior alveolar nerve block. This may occur why? Because of the spasm of the medial pterygoid muscle. Your needle must have penetrated the medial pterygoid muscle, leading to a spasm of it and leading to trismus. A very commonly asked MCQ. You people must have come across this. Clear? Next, you may come across with a trismus in a zygomatic arch fracture. Why? Because of the interference with the coronoid process. When the zygomatic fractures inwards, the arch fractures inwards, the coronoid process is interfered, leading to trismus. Okay? Next is the zygomatic mandibular fractures. They cause trismus usually due to pain and muscle tenderness. Okay? In mandibular fractures, the trismus is usually because of your pain occurred due to the fracture or because your muscles have become tender, which actually leads to trismus. So everything which causes a trismus has a definite reason. In an inferior alveolar block, trismus is due to spasm of medial pterygoid muscle. In zygomatic arch fractures, the trismus is due to interference with the coronoid process. In mandibular fractures, the trismus is because of pain and muscle tenderness. Clear all of you? People are getting me? Okay. Next is the dislocation, subluxation and hypermobility. Now what happens is when your mandibular condyle gets moved anteriorly, it is obstructed by the articular eminence so that it does not go ahead. It's like a speed breaker. But if it tends to go beyond the speed breaker, what will happen? This is your normal placement of condyle. If it tends to go ahead of the articular eminence, there is a dislocation occurring of the mandible. Okay? So that is a dislocation. Now, when it's a complete acute dislocation, it is also known as luxation. But if the dislocation is not complete, that means if it has not gone completely beyond the articular eminence, it has not completely gone across the speed breaker. If this is your articular eminence and this is your condyle, in a subluxation, your condyle may have been just gone till here or till here. It may not have completely crossed the barrier like in a dislocation. So you can say subluxation is a partial dislocation and it is also known as hypermobility. Okay? Both the terms are same. So don't get confused because an MCQ may be asked on either of the two. So both mean the same. Okay? Clear with what is complete dislocation and incomplete dislocation? Luxation and subluxation? Okay. Now, if there is a unilateral dislocation of the jaw, where will your chin go? Just try to imagine that your left side has dislocated. So your chin will deviate to which side? It will deviate to the left side or to the right side? Yeah, to the opposite side. Because it is already dislocated from your one part. So it will obviously tend to get pushed towards the other side. So, there are a lot of confusions because in unilateral dislocation, unilateral fracture, unilateral ankylosis. We'll come across this later again. For time being, you remember that in a unilateral dislocation, the chin moves to the opposite side, okay, or to the contralateral side. Now, okay, there's a brain teaser. Which side does the lips move while smiling in the cases of Bell's palsy? The affected side or the unaffected side? Okay, you have one side affected and one side unaffected. Okay. This is your affected side. If you tend to smile, where will your lips move? It will move to the unaffected side because it cannot move on the affected side. It's already paralyzed, right? So your lip will tend to move on this side. Okay? Now, we are talking about dislocation. So how do you manage? In an acute dislocation, sometimes while doing a dental procedure, or sometimes due to extensive opening of the mandible during singing or talking or blowing an instrument, the mandible tends to get dislocated. That's an acute dislocation. So what do? Is you place your thumbs on the occlusal plane of your molars, okay, and move it downwards, backwards and upwards. Okay, it is downwards, backwards and upwards. Okay, backwards and upwards is you're going back into the articular eminence. Why is it downwards first? What are you trying to do when you're moving the mandible downwards, then backwards and then upwards? What are you trying to? You're trying to unlock it, you're trying to obstruct. There is this articular eminence is here, right? So first you need to go down, the articular eminence. You need to go above the speed breaker to go back into the place. Exactly. Okay, so this is how you manage an acute dislocation. Now, in a chronic dislocation, chronic recurrent or habitual dislocations, there are some people who tend to commonly dislocate their mandible and they can usually place it back because of it occurring commonly. They have learned the tactic of actually putting the mandible back into place themselves. They do not need a dentist. But in such patients, if you need to do a treatment, you should tend to limit the TMJ movements, okay? Like the patient should be advised that during singing, talking, smiling, laughing, yawning, he should tend to stabilize his mandible and not open it much, which will actually lead to dislocation. He should limit his TMJ so that it does not cause a dislocation. The other thing is you can use sclerosing solutions which are put into the joint space by intra-articular injections. These sclerosing solutions are sodium silate, sodium morovate and sodium tetradyl sulfate. Okay, you need to know the names. They may be asked as MCQs. So you got the treatment between the acute dislocation and the chronic dislocation. Now there are surgical solutions which is divided into 5 categories by Miller and Murphy in 1976. Now what you do here is, it is divided into 5 categories. The first category is capsule tightening procedure. Okay, now we already saw how the capsule looks. This is your capsule around the condyle. What you need to do is tighten this condyle, okay, tighten the capsule. You try to tighten the capsule and make it tight so that the condyle does not get displaced anteriorly again and again. Because the capsule has become so lax that it tends to displace the condyle. So one of the procedures is capsule tightening procedure. Here you have capsulography where you tend to shorten the capsule. No, the right won't limit TMJ movements. You already need to limit the TMJ movement to a certain extent because in such patients, the TMJ movement is leading to anterior dislocation. So to prevent that, we need to limit the TMJ movement to some extent. You do not have to tighten it so much that it actually restricts it. You just need to tighten it a little bit so that it prevents the dislocation of your condyle anteriorly. Okay? So you either do a capsulography where you shorten the capsule or you give a vertical incision and overlap the capsule. Now if this is your capsule, in stainless steel crowns have how you give a V-shaped incision and then tend to overlap. It is something similar to that. You make an incision and then you overlap the two fibers of the capsule so that it becomes tight. Okay? Next is turning down and suturing a strip of temporal fascia. What you do is you remove a part of the temporal fascia and put it onto your capsules and tighten it over there so that your capsule becomes tightened. So these are the 3 procedures by which you in fact tighten your capsule. The next thing you can do is create a mechanical obstruction. Now, what is your mechanical obstruction in a normal person which prevents the anterior dislocation? What speed breaker is present there? Yeah, the articular eminence is present there. So now you want to create a better mechanical obstruction, so that because your articular eminence is not working in certain cases, so you need to create your own mechanical obstruction. Now this is given by many authors. First person is a Lindemann. He did an osteotomy and turning down of the eminence. He cut the eminence a little and he turned it down and sutured it into place. Now if this was the eminence, he made a cut in the eminence and he sutured the eminence to a lower position so that the speed breaker was restored back. Okay, he made a slight cut, an osteotomy was done and then it was sutured at a much lower position. This was done by Lindemann. Next, Mayer placed a graft on the eminence and this graft was obtained from the zygoma. Okay, in this figure you can see a graft is placed on the articular eminence. It is taken from the zygoma process so that your articular eminence becomes a better speed breaker and prevents the anterior dislocation of the condyle. Okay, getting me all of you? Okay, next is the Daughtry. In Daughtry, he did an osteotomy of the zygomatic arch and depressed it. Now what he did, the graft will be placed on the articular eminence, Dhara. Here is your articular eminence, right? A graft is placed here. You can see this. An additional graft is added. There is no space in the joint. No, you're on the articular eminence. It is not inside. It is in front of the joint. It is over your joint. It is not between the joint. Okay. Okay. Next is the Daughtry's procedure. Now what here he did an osteotomy of the zygomatic arch. Okay. He broke the zygomatic arch. He slit the zygomatic arch here and he then put the zygomatic arch at a lower level so that a step was created. And this step could then serve as a speed breaker for your condyle. Okay. If this zygomatic arch comes and gets placed over here, it tends to act as a speed breaker and prevents the displacement of the condyle anteriorly. Okay? Got it? Daughtry, he just removed the zygomatic arch from place and placed it a little below. Okay. Sorry. Okay, next is Findlay. Findlay inserted an L-shaped pin in the zygomatic process. Now what he did was, he put an L-shaped pin over here. He put an L-shaped pin like this over here, which tend to act like a speed breaker. Okay? He just put the pin inside your articular eminence or before the articular eminence, which prevented the anterior dislocation of your condyle. So clear with all the procedures? Lindemann osteotomy and turning down the eminence. Mayer placed a graft. Daughtry did an osteotomy of the zygomatic arch. This is a very important MCQ asked. Findlay inserted a L-shaped pin. Now the third he said was you could directly restrain the condyle. How could you restrain the condyle? A temporalis fascia is turned down and sutured. We came across this in capsule tightening procedures where a temporal fascia is placed down and sutured to the capsule. Yeah, it is the same thing. The sling of the fascia lata, now what he did was, this is your zygomatic arch and this is your articular eminence. This is your condyle. They made a hole in the zygomatic arch and a hole in the condyle. Okay. And then what he did, he took a fascia lata and he passed the fascia lata through this hole and tend to tighten. Okay. So this actually tend to restrain the condyle in its place and prevented the anterior dislocation of the condyle. Clear all of you? Through hole in the zygomatic arch and a second hole in the condyle, it was tightened. Next is creation of a new muscle balance. Here the muscle was targeted, the muscle was shortened and severed, and a scar was created, which actually you created a new muscle balance for the patient, which prevented the anterior dislocation of the mandible. And finally he said removal of the mechanical obstruction. What Miller and Murphy said that instead of trying to create speed breakers, just remove the speed breaker completely. Let the mandible go, let the condyle go ahead and come back on its place normally. Okay, what happens is when your condyle goes ahead, it cannot come back to its place because of your articular eminence. Right? So what you do? You remove the mechanical obstruction only so that your condyle can easily go ahead and come back to its place. There is no problem at all. Okay? So you either do a meniscectomy, a condylectomy, or an eminectomy, which is given by Myron. Okay? Clear all of you? No, it won't cause a permanent dislocation, Kamal. You are actually removing the obstruction. It will stay in its place only. But at times when the patient is having TMJ movement, it will tend to come out of its place and go back on its own. There won't be a dislocation occurring. It will go back on its, you are creating a new, I guess it must be the lateral pterygoid muscle because it is the most closely placed there. But I'll just get back to you on this. I'm not very sure. Okay? Yeah, I'll get back to you on this. So you remove the mechanical obstruction by 3 procedures. Meniscectomy